SMART Registry was initially established as an institutional database for the purposes of auditing the clinical outcomes of hip and knee replacement. Over the past 15 years, it has expanded and evolved in scope to become a repository of in-depth and rich data that informs just about every facet of our clinical research program here at the University of Melbourne Department of Surgery, St Vincent's. SMART is an institutional registry established in 2005 that captures longitudinal data on the clinical and functional outcomes of people undergoing hip and knee replacement surgery. In its earliest form, SMART captured demographic, surgery and inpatient data on all hip and knee arthroplasties performed at both St Vincent's public and private hospitals in Melbourne. Data from 1998 to 2004 was added retrospectively and prospectively from 2005 onward. Collection of patient-reported outcomes were introduced in 2006 as part of my PhD project, including both condition-specific and quality of life measures. From 2012 onward, we actually changed our condition-specific questionnaires from one that was completed by both clinician and patient to patient-specific questionnaires. So we currently collect the WOMAC and VR12 quality of life measure. Collection of hospital cost data was added in 2012, and this was followed by data linkage with the Australian Institute of Health and Welfare to capture data on pharmaceutical and healthcare encounters in 2018. Currently, SMART holds in-depth and near-complete data on more than 12,000 hip and knee replacement procedures. It grows by about 800 procedures per year, and this can fluctuate up and down a little bit. It contains more than 130,000 outcome surveys. We capture 100% of our surveys at baseline because we've embedded that into our clinic processes. And we get approximately 98% capture of 12-month follow-up surveys. And that 2% that we don't capture, we know what's happened to those particular patients. They're not necessarily lost to follow-up. They may be for reasons such as death or placement in a nursing home due to cognitive decline. The addition of the linked data has resulted in a data set that we now have over 650 variables to analyse. 3 million prescriptions and 10 million healthcare encounters also recorded due to that linkage. SMART unfortunately has no formal funding stream except for the data linkage component, which was funded for 5 years from the Opus grant. The estimated running costs probably in the order of $280,000 a year, which does actually compare favourably when you think about how much it costs to run a clinical trial. SMART is a highly productive venture. To date, we've had 60 publications arising using SMART data. 16 PhD candidates have or are using SMART data to inform their research, and it has actually been used quite successfully for pilot and feasibility data when we're putting in our grant applications. And we've actually been successful in 10 major grant applications that have directly used SMART data as pilot information in those applications. Aside from productivity, there's also SMART has had real impact. Our published manuscripts include data on clinical outcomes, health behaviours, health economic evaluations, and patient-reported outcome measures. And these publications have been highly cited in the Royal Australian College of General Practitioner guidelines, the Victorian Model of Care for Hip and Knee OA guidelines, the International Consensus Document on Prosthetic Jointing Management, NICE evaluations, and WHO policy documents. Our 16 completed or current PhD candidates are from diverse disciplines: nursing, physiotherapy, medicine, social sciences, health economics, engineering and biostatistics. And they're studying diverse topics including satisfaction with surgery, opioid use in surgery, Indigenous health, quality of life gains, health literacy and machine learning. And it's just worth noting there that we've seen quite an expansion of PhD candidates since we launched the NHMRC CRE OPUS. We've leveraged quite effectively the expansion and evolution of SMART to use as pilot and feasibility data for grant applications. And to date, SMART data has informed 10 successful grant applications with funding worth more than $10 million. And this has mostly come from the NHMRC. The largest project arising from the SMART Registry to date is our SMART Knee project. And SMART Knee is a project funded by the NHMRC Partnership Scheme, partnering with St Vincent's Health Australia, Medibank, Musculoskeletal Australia and the Australian Orthopaedic Association. SMART Knee is a decision support tool for knee replacement surgery for use by surgeons, and it also includes a feedback portal on patient outcomes. It has already been implemented at St Vincent's Public and is for future wider rollout across the St Vincent's Health Australia network, pending the easing of COVID restrictions. I just wanted to share a couple of screenshots of what SMART Knee looks like and how it works. The tool is based on a clinician and patient input and produces a probability of response or non-response to knee replacement surgery according to evidence-based criteria. So basically, patients come in and fill out some condition-specific and quality of life surveys, and surgeons record some clinical information about the patients, and then a probability of non-response to knee replacement surgery is provided, or risk of probability of non-response. And this has all been worked out based on SMART Registry data. And then surgeons can opt from there, whether in consultation with patients, whether surgery is the best option for patients, or refer them for non-surgery management. And basically, if their surgeon ticks non-surgery alternatives, then there's a built-in referral mechanism where a referral is automatically sent to our orthopaedic, our clinic, where they're seen by a clinical physiotherapy specialists for a plan for non-operative treatment. And this is what the feedback portal looks like. So once a surgeon has a minimum number of patient encounters recorded in SMART Knee, they can extract or review de-identified data on their patient outcomes, and then they can choose to benchmark that against either their own hospital, surgeons at their own hospital, the health service, or nationwide. And it has some built-in safety mechanisms around not being able to view data if there aren't enough cell sets. And they can look at a range of outcomes, such as clinical outcomes, length of stay, complications, etc. And they can actually look at how often they operated on someone who was considered appropriate according to criteria, and how often they operated on someone who had a high risk of poor response to knee replacement surgery. And then following that, they can actually look at their actual patient outcomes. And our main endpoint for the SMART Knee is to determine if it actually influences uptake of evidence-based criteria for knee replacement surgery. So what does the future hold for SMART? The ideas are endless, but we do hope in the near future that we can develop a SMART hip decision support tool. We're constantly looking at ways of expanding the data set through linkages with other databases, and we have a PhD student working on AI and hopefully being able to explore opportunities to develop risk prediction models using machine learning techniques. I'd just like to acknowledge the SMART team. Thanks for listening.